Welcome one and all. Welcome to today's Indians program on child and adolescent psychiatry. Today is the sixth session on CAP. We have all the other videos of CAP and also the other sessions of the Indians program is available in our YouTube channel, NIMHANS Indians. Welcome you all again. Today we have Dr. Sreyoshi who will be presenting on anxiety disorders, and we have Dr. Vandana Shetty who will be moderating the session. Over to you, Dr. Vandana. Vandana, can you please unmute the mic?
Yeah. Thank you, Dr. Chetan, for the invitation. I'm Dr. Vandana. I'm working in the Department of Child Psychiatry at NIMHANS. And today I will be moderating the session on anxiety disorders in children and adolescents. Our speaker for today is Dr. Sreyoshi Ghosh. She has completed her MD from St. John's and then her BM in child psychiatry from NIMHANS. And she's working as an assistant professor in the Department of Child Psychiatry at NIMHANS. I'll like to invite Dr. Sreyoshi. I'll hand it over to Dr. Sreyoshi to start the session. Any questions or doubts towards the end of the session? We'll take all the questions at once. Thank you.
Thank you, Vandana. And thank you all for logging in today. So I'll be talking to you today about anxiety disorders in children and adolescents. Right. So as many of you may be knowing, emotional problems, including anxiety and depression, are extremely common in children and adolescents, with prevalence rates of 10 to 20%. Now, if they are clinically significant and if they're of a moderate to severe intensity, it could be associated with difficulties in academic achievement, social and peer relations, and future emotional health. Now, as with many other child psychiatric conditions, anxiety disorders too are in fact associated with a lot of comorbid conditions and themselves also lead to comorbidity and increase the risk for comorbidity and psychopathology in adulthood. So because of all of these reasons, it's important for us to understand anxiety disorders in childhood and how they present and how we can really go about managing them. So what we will be seeing in the next few slides is essentially how to understand how different developmentally normative anxiety can be from anxiety that is in fact pathological. Because as I'll be showing you with the timeline, many fears and anxieties can in fact be a part of typical development. So we need to be careful before we diagnose a disorder. Essentially, if you are suspecting a disorder, then you would be looking out for anxiety that is very persistent and extensive, and also whether there is avoidance to the particular stimulus that is triggering the anxiety. So here, if we can see how, developmentally conditioned anxiety can in fact be distinguished from pathological anxiety disorders. So if you look at stranger anxiety, right? So that's actually normative between 6 to 8 months. Between about 12 to 18 months is when separation anxiety is normative, because this is a time when the child is first, has developed some level of attachment, is, starting to be able to walk around confidently. So at that time has also developed an idea of object permanence, which essentially means that, they understand that out of sight is in fact not out of mind. So because of all of these reasons, separation anxiety does develop, they miss the caregiver when the caregiver is away. It's not like in infancy when they would just assume that, if they can't see the caregiver, the caregiver has vanished. It's not that. They're able to hold that image of the caregiver in their mind. And so there is a certain sense of worry and a certain sense of insecurity. There is a need to return to the secure base of the attachment figure, all of which is normative between 12 to 18 months. Then we have between about the age of, early childhood, 2 to 3 years, Children may have normative fears of thunder, lightning, fire, water, darkness, nightmares. So this is actually what constitutes Piaget's pre-operational stage, right? So at this stage, the child has just passed the sensory motor phase, has developed some concept of his internal world, has started to develop fantasy, right? So at this stage, many things like lightning, thunder, fire, many of them may assume a very living quantity. So it's a feature of the pre-operational stage that's called animism, which comes from animated. So many of these things may be perceived by the child to be alive and animated, and hence there may be normative fears which are seen at this age. Then between the age of 4 to 5 years, there could be a fear of death or dead people, because these are still relatively mysterious concepts for children. They don't understand irreversibility of death, which happens later, about 7 to 8 years. Right? So when do we really distinguish these developmentally conditioned or normative fears from the corresponding anxiety disorder? That is, if you have any of the symptoms in the middle, that is psychopathologically relevant symptoms like sleep disturbances, panic attacks, excessive crying, clinging, withdrawal, freezing, right? Avoidance, very significant avoidance, enuresis. Of course, enuresis before the age of 5 years, we will not diagnose, but if it's a new onset or a secondary enuresis, that is the child who has already gained continence, now again develops new onset enuresis, all these things may lead you to wonder whether the normative anxiety has in fact now progressed to the corresponding anxiety disorder, which could be separation anxiety disorder or specific phobias or even GAD. Now, later on, as children grow up, so specific phobias, as we see, fear of specific objects, animals, monsters, ghosts, it's in fact the most common type of anxiety, specific phobias, could usually manifest a little later on, but what we see is between the age of 5 to 7, even these are largely normative. Now, as children grow older, the social anxiety part of it, right? We know that they go through stages of industry versus inferiority, where they kind of match themselves up against their peers. And then, of course, in adolescence, there are very strong social challenges. At this developmental phase, some amount of school-related anxiety with regard to performances, with regards to how they're doing with their peers, is again considered normative. Now, if it becomes extreme, right, extreme shyness, feelings of shame, a strong fear of negative evaluation, then we need to consider whether this is in fact not really normative and whether it warrants a diagnosis of social anxiety disorder. This is the same thing, similar to what I was discussing about how really the normative anxieties can be differentiated from anxiety disorders. So as you can see, if you look at the timeline at the bottom, in infancy and toddlerhood, that is when separation is a major feature. Then in childhood, you have more of the specific phobias, moving on to more of social and anxiety related performance, rejection fears in adolescence. That's normative. If you have any of these psychopathological symptoms that may be present, then you would need to think about whether in fact to consider a diagnosis that you see above, whether it's separation anxiety disorder or GAD or even social anxiety disorder or social phobia. The blue lines essentially indicate what different types of course and outcome anxiety can take. So like we know OCD can be waxing and waning. Remitting you may actually see. So many times we have young children who may actually have a clinical diagnosis of separation anxiety disorder. Many times we do end up seeing that they could remit by the time they reach middle and late adolescence and adulthood. Some children, of course, may have a persistent kind of a course. We see children with some children with generalized anxiety disorder, some children with social phobia. Certainly, many of them have persistent courses, and in some, it may even be progressive. So these are the anxiety disorders as they've been categorized in DSM-5. Now, the reason why we're focusing more on DSM-5 is because ICD-10 doesn't really say a whole lot about anxiety disorders in children and how you may want to distinguish it from anxiety disorders in adults. But DSM does. There are certain specifiers that are given which help you to make the diagnosis in children and adolescents as well. Selective mutism is a new diagnosis in DSM-5, essentially where children find it very difficult to speak and to communicate with other people, especially outside familiar settings. Both for selective mutism and for separation anxiety disorder, the time criteria that has been specified in DSM-5 is symptoms for more than 1 month, which is actually more for adults. It's about more than 6 months for adults, but for kids, symptoms more than 1 month would warrant a diagnosis if all the other criteria are met. With regards to specific phobia, social anxiety, panic disorder, agoraphobia, GAD, there are not too many differentiating factors from adults. In generalized anxiety disorder, apart from the feelings of worry and apprehension, we've listed a whole bunch of other symptoms like insomnia and fatigue, physical symptoms basically. So in children, the symptom threshold is less. So you need only one out of all those symptoms, whereas in adults, there is a higher symptom cutoff. Now, obsessive compulsive disorders and all the trauma and stress-related disorders have actually been moved out of anxiety disorders. They are no longer classified together. And in this talk, I won't be covering any of these. So if we were to just look at some of the core features, if we were to understand the clinical symptomatology, so separation anxiety is really characterized by a fear or a concern that something bad will happen to the child or the attachment figure, right? And as a result of this belief, the child will avoid separation from the attachment figure. Many young children who present with school refusal may in fact have severe separation anxiety. So if you have a child with school refusal, you should consider whether separation anxiety may be a contributing factor, especially if it's a young child. In older children, of course, it may be social anxiety. There may be other familial related factors as well. Now, how does this manifest? So the child may talk to you about dreams or nightmares about separation, refusal to face situations that involve separation, worry about the consequences of separation, including fears of being kidnapped or injured, or of the attachment figure being hurt. And there could be a lot of physical symptoms as well when separation is anticipated, including vomiting, diarrhea, and stomach aches. Now, many a times in children, because they are not often able to give us a very clear verbal account of their symptoms, so we have to look for behavioral phenotypes. So if we are finding a lot of headaches and stomach aches, which don't seem to really have any medical basis, we have to think about whether there could be a functional basis. And more often than not, there would be an anxiety disorder or maybe even a depressive disorder that could underlie some of these unexplained medical symptoms in children. Now, with regards to GAD, like in adults, there's a tendency to worry about a wide range of negative possibilities that something bad would happen. Of course, the area of worries is a little different in children. So, they may worry about friendships and schoolwork, sports performance, and maybe even day-to-day issues. Now, many children who have these worries, they compensate for it by trying to be extremely perfect. So this is something that we see in a lot of kids with GAD, that they also develop perfectionism as well. They may have a tendency to repeatedly seek reassurance from parents or others about fears. And certainly, like with other anxiety disorders, there would be some element, they would avoid, like I said, making mistakes. So if you avoid making mistakes, of course, it means that you're trying to be extremely perfect. And you could have physical symptoms, sleeplessness, and irritability as well. So social phobias are, of course, fear and avoidance of social interactions or social performance due to a belief that others will negatively evaluate the child, which could be associated with avoidance of a range of social activities, including speaking or performing in front of others, meeting new kids, talking to authority figures, being the center of attention. And what DSM does specify is that although it may be generalized, many children have social phobia that is limited or circumscribed to primarily performances. So there is a performance only specifier that is also present in DSM-5 for social phobia. So with regards to specific phobias, the core feature is of course fear and avoidance in response to a range of specific cues, situations or objects. And some common ones are of course animals, insects, the dark, loud noises, especially storms. Panic disorder and agoraphobia, they've come at the end because they are relatively uncommon in children especially, and even in adolescents. We may see it more perhaps in late adolescence or early adulthood. It's not that you cannot have panic attacks. Many a times we have had children who've had panic attacks, but they are sometimes spaced out. You don't usually make the diagnosis of panic disorder in youngsters. The symptoms, of course, are completely similar to that which you see in adults. So with regards to the epidemiology, what you can quickly make out from this slide is that specific phobias are, of course, the most common in terms of the lifetime prevalence. If you notice, all of the anxiety disorders are more prevalent in females, right? And of course, your lifetime prevalence does, again, more in females. And what we can see is that the prevalence is relatively high. So if depression is kind of in, 1 in 5 individuals, then, we're seeing that anxiety also, lifetime prevalence total, if you look at it, it's 31.9, right? So again, and these figures are more or less similar globally. So, I mean, some people get 10%, some have gotten 20, but overall it's, what needs to be remembered is that it's extremely common. Okay, so I think we've got a rough idea about this from the previous slides. So the fact that animal phobias, that is specific phobias, as well as separation anxiety disorder, we would make the diagnosis around 7 to 8 years of age. GAD, later on in later childhood, about 10 to 12 years. Social anxiety disorder in early adolescence, about 11 to 13 years. OCD probably in around mid-adolescence, and panic disorder around later, that is in early adulthood. Now, as you can make out, the age at which these disorders typically would start manifesting also kind of parallels the way in which developmentally anxiety is manifested even normatively. So the same disorders that you would see normatively first in an individual's life are also those that would manifest earliest in terms of the disorder, right? Separation anxiety, what we know, is common between young children between 1.5 to 3. If we're seeing it persist beyond the age of 6 at around 7 or 8, that's the first disorder that you would diagnose. Whereas social anxiety, which we would think, okay, they have some social worries and challenges in early adolescence, that itself, if it becomes pathological, you would diagnose it around that time, which is early adolescence. Okay. So like I was saying right in the first slide, we often have anxiety disorders that cluster together, right? So you may have one that has emerged, but then you may have multiple anxiety disorders that often develop by adolescents or early adults. The research has been kind of mixed on how persistent they are. So in one important study, they said that about 50% of kids, continue to have symptoms, whereas 50% of children diagnosed with anxiety did remit. So there is a tendency for maybe about half of our kids to have a persistent cause. Now, the load of anxiety seems to contribute to the development of secondary psychopathological complications like further anxiety, major depression, substance dependence, and suicidality. The last point is essentially talks about homotypic versus heterotypic continuity. So I'll just explain what that is first. So homotypic continuity is when we notice continuity between early temperament or early risk factors, like for example, children who have a lot of inhibition, right, behavioral inhibition, or who have very inhibited personality, that trait continuing into social anxiety. That is kind of homotypic continuity. And heterotypic continuity is when you may have a child who has anxiety initially in childhood, and then later on they may move on to develop a slightly different disorder like depression. So that is heterotypic continuity. So essentially, there is a substantial degree of continuity, right? So it may not be that the same disorder, so separation anxiety may not, in childhood, may not be separation anxiety in adolescence, but it may have actually become panic disorder in late adolescence, right? So those two are somewhat correlated there. So that's a broad homotypic continuity. So continuity within the broad cluster of anxiety disorders or other disorders, for example, like depression. So anxiety and depression are the most classic examples of heterotypic continuity. Very, very often we have children who have anxiety in early childhood and they develop depression, or they're at higher risk to develop depression in adolescence and adulthood. So this is a very typical example of heterotypic continuity. So what would be the risk factors? So the female gender definitely has been linked with higher risk for emotional problems, including anxiety. Parental anxiety disorders for a number of reasons. The first being that anxiety is thought to be at least 40% heritable, right? So some endophenotypes have been identified with anxiety disorders, autonomic functioning being one, respiratory dysregulation being the other, right? So some of these features, like for example, a very high reactivity. So with a certain small stimulus, if the person's autonomic nervous system tends to just go into overdrive, or if their heart rate speeds up, and there's a great release of adrenaline. These are all some things which may actually be inheritable, and we may see them very, very biologically or constitutionally, right? So in that way, of course, the parent may be passing on some of these traits to the children. And then, of course, naturally, if you have an anxious parent, they're going to model a lot of anxious behaviors, including avoidance, for their children, right? So that in itself may be environmental factors that further contribute. Now, personality trait vulnerabilities. So, different people have called it by different names. So we have the ocean traits, which includes neuroticism. Then, some people call it trait anxiety, which you can, pick up with different scales like state trait anxiety inventory, negative affect, as well as temperamental styles such as behavioral inhibition. And all of these are likely, they have some level of overlap, but they can certainly be viewed as precursor conditions to anxiety disorders. Now, one particular important thing in this that I'd like to highlight is behavioral inhibition. So it's a construct that was given by Jerome Kagan, and he found that toddlers who are about 2 to 3 years of age, if they tend to be extremely withdrawn in normal situations, in novel situations, then that often precedes the development of anxiety disorders. And the most compelling evidence is the link between behavioral inhibition and social anxiety, which is a kind of a typical sort of a homotypic continuity that I was talking about. And this behavioral inhibition is also linked with high infantile reactivity to stimuli. So again, a fast increase in heart rate, autonomic hyperarousal on presentation of novel stimuli. So this construct has been very, extensively studied and is certainly linked to the development of anxiety. Now, of course, when we talk about temperament, we like to ask about whether, what is the predominant mood state of the child in infancy? So is there a high level of negative affectivity? Now, that's not specific for development of anxiety, but it's said to, kind of predispose to both anxiety as well as depression. So children who have, predominantly a very cranky, what we call a difficult temperament, right? So difficult to soothe, easily upset. Now it's a mistaken kind of an understanding that difficult temperament links up only with externalizing symptoms like ADHD. That's not really the case. If we have a lot of negative activities, affectivity, stormy moods, difficult to soothe, you may certainly see that as something that predisposes anxiety and depression as well. The kind of physiological hyperarousal or the reactivity that I was talking about in infancy is more specifically linked to anxiety, whereas low positive affectivity is more specific to depression. Now, certainly, when we look at anxiety that has become a disorder so early in life, we need to think about whether there are negative life events or stressors that have brought forward, the presentation to childhood and adolescence. So it has been suggested that threat events tend to precede anxiety disorders, and we know that this is possible and that you can have phobias and phobic disorders actually getting precipitated by single exposure events, right? So the fear conditioning can happen when there is a high threat perception. Parental factors like overprotection and parental rejection were associated with increased risk of social phobia in offspring. High levels of parental coldness and authoritarianism were modestly associated with increased risk for nearly all disorders. So what is important to remember here is when we think about the child, we think about the parent, it's important to try and identify whether what is the level of goodness of fit between the child's temperament and some of these parental factors. So for example, if you have a child who is extremely socially anxious, right? So this child is automatically going to be avoiding a lot of socially evaluative situations. Now, if the parent is also anxious and tends to overprotect and prevents the child from really engaging with his or her environment or exploring, or in a graded way, his or her social environment, then naturally this child is also not going to develop the requisite social skills that are required as he or she proceeds along the developmental trajectory. And if they don't acquire the skills, then they're going to be even less capable for participating in the demands that are required, and then that would in turn increase the anxiety. So that kind of thing is not a good fit. So there's a lack of goodness of fit. Similarly, if you have a very anxious, behaviorally inhibited, highly reactive child, and you have a parent who is either rejecting or high on authoritarianism, so high on control, right, very over controlling, then automatically this would make the child's anxiety much worse, right? So again, you don't have a goodness of fit there, and it's likely that these constitutional and parental factors are then going to interact to increase the level of risk for this particular child. Now, when, of course, after our clinical assessment, when we are assessing the child for anxiety, we can use questionnaires, we can use diagnostic interviews, but the most important thing is, of course, your history and your behavioral observation. Now, if the child is able to verbally talk to you, then it's a good idea to have a separate interview with the child. You may have anxious parents who may exaggerate symptoms, and many a times we have anxious kids who minimize their symptoms. So at times in such situations, self-rated questionnaires have sometimes helped to tap anxiety symptoms that children may not very quickly come out. Of course, if you have several comorbid disorders, the way to go would be to determine which is the primary disorder causing the maximum dysfunction and treat that first. Now, there are several assessment scales that are available. The one that we use is SCARED, which is Screen for Child Anxiety Related Disorders. So there's a parent version and a child version. And it's a screening tool that gives you an idea about whether this child has anxiety at all, and whether they have different kinds of anxiety, like, for example, panic, separation, social phobia, etc. So that's a useful scale, to try and tap different forms of anxiety in children, and also even for following up and checking response to treatment. These are some diagnostic interviews. So the DISC is one that can be used even without a lot of training. The one that we have most experience with is, of course, MiniKit. It's a fairly useful instrument, has a lot of questions according to the diagnostic criteria. Others like the KSADs, they are for clinicians and they require some amount of training, and also many of these are paid instruments. So I would suggest that you go through the MiniKit and you're kind of familiar with that. Now, coming to the management, the reason why I have put psychotherapy first is essentially because if you're able to offer high quality psychotherapy, then there is research that tells us that it does pretty much as well as medication. Now, the best thing for severe anxiety is, of course, to go for a combined approach. But what we do believe in is that far as possible, the mainstay of treatment of anxiety disorders in children really ought to be psychotherapy, which is why this has come first. Now, the coping cat model for anxiety is, kind of like a gold standard CBT program, which has been used in many of the multi-site RCTs that have been conducted for anxiety disorders in children. So you won't find that, the CBT aspects of this are very different from adults. The main principles are essentially the same. So you have psychoeducation, then you have affective identification, somatic management, cognitive restructuring, behavioral exposure. Of course, very importantly for children, you need a lot of family involvement and relapse prevention. So we'll go into a little more detail about these. So in psychoeducation, you would of course want to help the child and family understand the nature of anxiety and how CBT would specifically work. Now, why you would want affective identification is because many children, and indeed many older people as well, may not really be able to identify, what is anxiety or what are different emotions, how are they linked with different kinds of physiological states. So you would want to do some, activities to help children really get in touch with what are their different emotions and how do they identify it and early signs of experiencing that particular emotion. After you've done that, then they would start to link a particular mood state with the cognitive component, right? So, they'd feel a particular way, they'd learn to, identify anxiety that they're experiencing, and then ask themselves, what are we thinking now? What are the kind of anxious thoughts that are going on? And then teach age-appropriate ways for the child to engage in more balanced and coping-focused thinking. Now, after you've done some of this basic work, until and unless you do a behavioral exposure, the efficacy of the treatment program is not really going to come about. So in the behavioral exposure, which is the second part of the CBT model, you're going to actually design first imaginal and then in vivo exposures to enable the child to practice the skills that they have acquired in the first part of the program. Family involvement cannot be underemphasized, because parents can provide valuable information, and they would also need to coach him or her through behavioral exposures, and also definitely give rewards when the child is able to perform that particular behavioral experiment. In relapse prevention strategies, you would want to consolidate whatever you have already taught in your previous sessions, maximize treatment gains, and then design coping plans for future obstacles. So this is the FEAR plan. So the FEAR acronym that is a part of Coping CAT. Also to kind of help children and parents to remember the components of the program. So F is for feeling frightened, E for expecting bad things to happen, A for attitudes and actions that might help, and R for results and rewards. So like we said, initially, it's important to go for affective identification. So the first part of the FEAR program, which is to identify the physical symptoms associated with anxious arousal. And then, of course, what do you do with that? So, you're taught to engage in certain relaxation strategies, which, of course, should be age appropriate. So for children, we often teach them things like belly breathing. You have a lot of mindfulness programs also, which are more, targeting children and the kind of metaphors that they may understand. Many kids learn better through pictures, through videos, through demonstration and role plays, right? So when you do this kind of role play, then automatically they would understand what are these different emotions and what are the physiological symptoms that are linked. Okay, then we go on to the cognitive part, which is do they expect bad things to happen, right? What are the cognitions that are really behind the anxiety? What is the kind of self-talk that this child is typically engaging in? So that's a part of the cognitions. And then when you are evaluating evidence for and against the anxious self-talk, when you're trying to replace anxious self-talk with more positive self-talk, right? So if the child, for example, keeps thinking, oh my God, everything is going to go wrong, everything is going to be terrible, right? If they can just, kind of supplant that with the thought that things are going to be okay, I've done this before, I've got it, don't worry, that's often easier in a moment-to-moment basis for the child to do, than going through a very detailed kind of Socratic question. So sometimes, if the child is not very, comfortable with engaging in a lot of verbal discussion, you could use cartoons with empty thought bubbles to try to get them to talk about what they're experiencing. And then after this, you could, gradually move from, so when you're talking about self-talk, then you could move from initially non-stressful situations to ambiguous to more anxiety-provoking situations. This is all if, the child is not very comfortable with talking about anxiety and, like difficult mood states, then you could go with just thinking about non-stressful ambiguous situations. What are the thoughts that would accompany those, and then move on to more anxiety provoking situations. So when we talk about attitudes and actions that might help, so this is where you would want to teach a little bit of problem solving. Now, problem solving is actually a very transdiagnostic approach, especially in child psychiatry. So we teach problem solving across the board, whether we have a child with anxiety or whether we have a child with conduct issues, right? Because it's a very essential life skill that that is really required for kids. So how you would go about that is to help the child define the problem and generate all the possible solutions for the problem, and then to kind of evaluate the pros and cons of each possible outcome, and then select one and make a plan to try it out, right? So this is how the child can kind of make sense of that particular problem and how they want to go about tackling it. Now, as they're acquiring all of these skills, they would certainly be practicing them in the session under conditions that involve increasing degrees of anxiety, right? And so they would learn all of these, and then they would practice this entire thing in exposure sessions with the help of the therapist and with the help of peers and caretakers. Now, for any program with involving children, you can't really underestimate the importance of rewards, right? So when a child is able to achieve a new skill or able to achieve a new goal, it is certainly useful to have some kind of a contingent reward system. So this is kind of just a summary of what we were talking about. So it's totally a 16 session program, like most CBT programs. So it would probably go on for about 4 months or so. So in your initial steps, you're going to be talking about your treatment goals, doing your psychoeducation, build rapport. You start with identifying emotions, teaching children about different emotions through games like the feeling charade. Then you're going to go on gradually to introducing relaxation training, looking at whether the child has anxious self-talk, how will you change that into coping self-talk, teach them some problem solving, introduce rewards, and then put the entire thing together into the fear plan, which is then going to be implemented in the second half of the program, which is obviously going to be harder when you are going to be exposing them to the situations that they find difficult after preparing a hierarchy. So you can start with both imaginal exposure, which then moves on to more, challenging in vivo situations. At the end, of course, you would want to consolidate. So either, they've talked here about preparing a commercial, or you could just kind of prepare a diary. Sometimes we like to consolidate learning by preparing a story, maybe with the child's favorite animal or favorite superhero, about what was the experience, what were the things learned, and they can make a little book out of it, which they can then keep for future reference. Now, of course, the involvement of the caretaker is extremely important. One would be, of course, during the skill building phase, and the other just before beginning exposures, to collaborate on treatment plans and discuss the concerns. Now, as we've said right in the beginning, in the risk factors, parents of anxious youth often experience anxiety themselves, and so they may need a lot of guidance, and if required, they may need treatment themselves in order for the program for the child to be really successful. Now, for separation anxiety, I mean, as we have seen, this often manifests in young children where, a typical CBT package may not really be effective, although, we've attempted CBT for kids who are above the age of 7. But what we would want to do in a very simple way is to help children, again, identify what are their anxious feelings and thoughts with regards to separation, right? What are they feeling when this happens? How can they, help themselves to relax when they're experiencing this anxiety, right? How can they use more coping self-talk in a very simplified way, right? So if they think that your mom's never coming back or something like that. So how can they replace that with something that is really more realistic? And this is, of course, your individual, work with the child that you would want to do. Sometimes we like to do this work in a play setting. So play therapy is often viewed as something that is entirely psychodynamic, where you kind of just, sit back and it's very non-directive and you let the child take over and you keep reflecting, but it's not necessarily so. You can have cognitive elements also that are weaved into a play therapy setting, right? So with the child's favorite dolls or favorite animals, you can in fact, put them in different situations, you can enact, and then you can teach the child how to, first maybe help the doll or the animal cope, and then if they are in it themselves, then how they can cope themselves. So sometimes with younger children, you may want to use play material in order to teach some of these skills. Mindfulness is something that's becoming very popular, not just in adults, but also in schools. It's a part of many life skills programs, and they have found that it does have some amount of benefit. I'd just like to mention here that you could use mindfulness, but it has to be used with some level of understanding and care. So for example, in some children, if you directly move to mindfulness of thought, right, then it could be very anxiety provoking. So it's best to start with, gradually with mindfulness of breath, then sensation, and then, later move to perhaps mindfulness. But when used judiciously, it can be certainly a good tool to have. Now, pharmacotherapy wise, so of course, the only way to go is SSRIs. We don't prefer to use other medications, not that there isn't evidence, but the side effect profile is usually, not in favor of medications apart from SSRI. So if, you're treating with an SSRI and you feel it's kind of working or not worked too well, you should probably just switch between the class and try a different SSRI. Now, the kind of doses that you see here are quite high, actually. We often don't need such high doses. So 25 to 200, as you see of sertraline there, is the dose range that was given. But the issue is that if you're dosing quite so high, you may run into a whole range of side effects, not least among which is one that's called behavioral activation, which is a big problem in young children, in kids who are started on SSRIs. It's more problematic in children as compared to adolescents, and much less in adults. So to avoid that, actually, in some kids, we start with doses, say, of sertraline as low as even 6.25, right? So there's a 10-year-old child recently whom I saw who has panic attacks and generalized anxiety, a lot of worries. And she developed very severe behavioral activation with fluoxetine. So what we've started her on is a very low dose of sertraline of 6.25. And after keeping that for about a week, then only I had gone up to 12.5. And this time she was able to tolerate. So it's just best to start very, very low and go slow with your medication. If you're able to offer CBT, you could go ahead with that first. It's not like you're compelled to start medication in all children. If in children with mild anxiety, you could completely avoid the medication altogether. In moderate to severe, yes, there is evidence of benefit, which is pretty much as as equivalent or kind of the same as that what you see with CBT. And of course, if you're able to, then the best thing to do would be to offer a combination therapy, especially if the child has severe anxiety. So combination therapy is something that across the board in child psychiatry has been shown to be more effective than monotherapy. So there's been a bunch of RCTs, and the one that you're seeing with sertraline, CBT in combination, that is part of a big RCT called CAMS, which is Childhood Anxiety Multimodal Study. And they did find that CBT SSRIs or the combination was better than placebo. And what they did find is the combination of CBT and sertraline was in fact better than either CBT or SSRI, which, I mean, the medication and therapy were more or less the same, but the combination was better than either of the two. So if you can, go for combination. Otherwise, either if you can offer psychotherapy, well and good. If you're going for pharmacotherapy, just start really, really low. I would prefer sertraline. If that's not working out or the child has some GI side effects that are troublesome, the next thing that I would usually prefer to give is fluoxetine. And also because these are medications that are also approved and have been researched in relatively young children. Whereas medications like escitalopram are more, well studied in adolescents, and even the FDA approval is for older kids. So I would just say start with sertraline if you want to medicate, and then move over to fluoxetine. If nothing is working, you should check whether there is comorbidity or not, whether there are familial issues that have been addressed or not, like parental anxiety. Add on your CBT, try for a combination therapy, and usually something or the other would work amongst these, because we don't really have a whole bunch of other options which are very effective. And especially things like your buspirone and all of those are, they simply somehow haven't really been shown to be efficacious in kids. So I'd just like to thank my colleague for his help with the slides. This is Dr. Arul. He was my colleague in DM.
Okay. Thank you for the presentation, Dr. Sreyoshi. I would like to invite any questions from the audience. You could either chat with us regarding your questions, or you could just indicate and I can unmute you and you can ask Dr. Sreyoshi. Any questions from the audience? Okay. I would like to unmute Dr. Vikram. He has a question. Yeah, Dr. Vikram, you can unmute yourself and ask your question.
Hello. Ma'am.
Yeah, go ahead.
Can you get
Please
me?
ask.
Yeah. Yes, yes. Thank you for such a enlightening lecture, ma'am. One thing I would like to ask that many a times maybe rapport building would be an issue where, as you say, that child was faking a good.
Mm-hmm.
So in that case, how can we go ahead and give him like situations like how can we proceed with the CBT basically?
Okay. As you very rightly pointed out, if you don't have rapport, and if the child is unwilling to talk about his or her problems with you, then that's naturally going to turn out to be very hard. So in such situations, it helps, especially in younger children, to do some kind of projective techniques like art, for example. So so if you suspect, for example, that the source of stress is within the family, right? Oh, sorry.
Yeah. Okay.
Is it on the video?
Yes, your video is on.
Okay, all right. So, for example, if you suspect that the source of stress is within the family, you could ask the child to draw a picture. It's something called the kinetic family drawing test. So you could ask the child to draw a picture of the family members doing certain things, right? Or doing anything, whatever the child feels like depicting them drawing. And very often in such situation, you may have some pointers. I had a very young child, about 6 years old, with school refusal, and he would completely minimize the problem, because very often they also may not want you to do something about the problem, because he likes staying at home and being with the mother and getting attention and all of that. But when he drew his kinetic family drawing test, he drew all of his family members doing something or the other, his father and brother playing cricket, his mother cooking, and he in fact was not at all in the picture. He completely eliminated himself from the entire family picture. So and when you ask him what would you be doing, he'd say that I'll be on my own, just talking to my play animals. So using some kind of projective material in the beginning, to really understand the problem, is often helpful. You could use RCPT, which is a Raven's Control Projective Test, which has a whole series of questions that are trying to tap different stressors, all of which are elicited from the child while he or she is separately engaged in drawing a picture, so that they're not, very aware of what they're saying and how you're interviewing. So some of these methods may in fact help. Of course, after you're able to get something from the child, some kind of a narrative, some insight into the problem, then you're in a position to actually collaboratively work with him to figure out some solution.
Yeah. Thank you. I would invite Dr. Jwalamukhi to ask and clarify the doubts. Yeah, go ahead. There seems to be an issue, so I'll read out the question that she had messaged. She wanted clarification on what should be the dosage and schedule for sertraline for generalized anxiety disorder.
It also depends on the age of the child. There is no exact dose that we can specify, but like I said, you would want to start low. So, young children maybe as low as 6.25, slightly older kids 10 and above, you might want to start with 12.5. I usually like keeping that dose for a week and then going up very, very slowly after warning the parents that there may be behavioral activation in the form of irritability, in the form of, insomnia, in the form of, being very oppositional and agitated. So you could reach a dose of about, say, in young kids, you could reach about 25 and then wait it out for a while, like really young children. In older kids, like teenagers, you could try to reach about 50, maybe if they're about 13, 14 years of age, and then wait. Just wait on that dose for 3 to 4 weeks and check if there is any improvement or not. If there is some kind of a response, then you go up further. If there's like a partial response, then you could go up a little further. Or if you're finding just with that dose, and if you're able to offer therapy, then great. That the child is doing quite well, then you need not actually go up further than that.
Okay, Dr. Pfizer, you can ask your question.
Yeah, it was a comprehensive presentation. Really, it was quite learning for me. I would like to know the anxiety disorders in children of alcoholics, actually the young children and the older ones, actually the children who witness parental marital discord and parental
Yeah.
abuse. So what sort of presentation do these children? Thank you.
Yeah. So there isn't any one specific disorder that would actually be triggered or precipitated by kids who, as you mentioned, may be belonging to very difficult families where there could be substance dependence and familial discord. So there's a range of internalizing and externalizing problems that we could actually see. Not something specific that has been identified. Possibly, if I remember correctly, I think the externalizing problems are a little more children who are difficult, who act out. Possibly again because of some kind of a genetic diathesis. You may have kids of parents with substance dependence who themselves have ADHD again as part of the inheritance. And then naturally, with that kind of a temperament, if they're further exposed to inconsistent parenting or very harsh parenting, then that would kind of worsen the situation. So you can see a mix, but I would tend to, kind of go more towards the side of externalizing disorders for, kids of parents with substance dependence and a lot of marital conflict and domestic violence.
Okay. Dr. Shashi, kindly you can ask your question now. Dr. Shashi? Okay. Dr. Shashi wanted to know what to be considered for separation anxiety, CBT or sertraline.
Okay, so separation anxiety earlier was thought to be more a disorder of childhood, and that it had to present before the age of 18. But now DSM has removed that, and they actually say that it can be present or it can even start anytime across the lifespan, right? If so, it would depend on the age of the child. If you feel that your child is kind of above the age of 7 or 8, is quite psychologically minded, able to kind of engage in a CBT process, you could go ahead and do your CBT. If it's a very young child, then you may have to go for a more play-based approach, or you may have to do a lot of behavioral work with the parents as well. For example, how to separate from the parents in a graded way, right? So the lowest step on that hierarchy would be that the child is just away from the parent, like at a short distance, but is able to see the parent, right? And for a short duration of time. And then you gradually increase that. So the parent goes to the next room where the child cannot see the parent. Then the parent goes outside for some time, but you set up a way in which the child can call the parent if he or she is, anxious or worried. And so for younger kids, you may have to do that kind of behavioral work, and maybe if you can get somewhere with play therapy, that would also be good. Or you could introduce CBT strategies within a play setting, like I was pointing out. So the child and his or her favorite doll can practice belly breathing together. It can be really simplified. So even young children can be helped to understand, but you would not want to do it perhaps in a pen and paper way that you would do with older people.
We have two questions on pharmacological management. One is regarding the role of clonazepam in anxiety in children. And the other one is pharmacological management for comorbidities, comorbid ADHD.
Okay, clonazepam we do use benzodiazepines. It's not that we don't. But the recommendation would be to use it for as limited a time as possible, really. So I like to usually start and give a low dose of clonazepam when I'm initiating an SSRI, because as I said, we are very worried about behavioral activation. So sometimes it just helps to tide over that first 2 weeks, when the SSRI is just starting to act. If the child has insomnia, then it deals with that early on. But I think once your SSRI has really been built up to a good dose and you feel that something's working, you should probably just take it off. With regards to comorbidity, ADHD, so there is research that if you use monotherapy with atomoxetine, that it helps both anxiety and the ADHD component So, you're kind of killing two birds with one stone. But again, it's a clinical decision. So if you have ADHD that is severe, right, and which is extremely problematic, and most of the child's anxiety is secondary to not being able to perform because of the ADHD, then you may want to use your gold standard medication like methylphenidate to treat the ADHD, because the anxiety is kind of secondary to that. You need to find out what's your primary disorder and institute the recommended treatment for that. So purists still say that if you have ADHD and anxiety, and try to figure out which is worse, which is the primary condition, and treat that. So they would still go for MPH and treat the ADHD and then see. But if you have kind of like mild to moderate anxiety, mild to moderate ADHD, then maybe you would want to go for atomoxetine because it's less effective than MPH, of course, for ADHD. So it's a clinical decision, really. But I have used atomoxetine for several kids with comorbidity. Like I said, it's worked for people with more moderate level of symptoms. So it's an individual kind of decision that you need to take.
Dr. Sreyoshi, I think we are nearing the end of the presentation. I would like to ask from my end, any practical tips on how to engage children with anxiety? Especially, I think, in terms of developing rapport and engaging them in the program.
Yeah, so I think in addition to what I've already said, it's important very early on to kind of set the context of why they are here and what is going to happen. We probably do that with all children, but more so for kids with anxiety. They don't know why they've been brought. They don't know what is going to happen. Is this some kind of a punishment? So I always make it a point to ask the kids who are sitting in front of me, do you know where you are? What have you been told? What do you expect? Right? Would you like to know something about me and what I do? It helps if your whole chamber is kind of child friendly and you have a lot of things, materials with which to engage the child. So you set the context really early. You tell them why they've come, how you intend to help, that it could be a gradual kind of a process. They're not going to be forced into anything. It's not a punishment. So many a times, that itself kind of helps kids to settle down, to tell them that they're not compelled to talk to you or to answer any of their questions. So I let them know, if you want, you can walk out. If you want water, you let me know. If you don't want, if you want to sit there the whole time and not say anything, even that's okay. So I think you need to give them that space.
Okay.
And that itself can be very important. So there was a child with selective mutism for whom I was doing play therapy. I think it took a year for the child to say anything in my presence. But that's just sometimes the time that it takes. So you just give them the space, and young kids, you take them to a playroom, which automatically brings down their anxiety, or keep some material in your room. And I think use projective strategies as and when you can, like drawings or toys or enactments. And I think a combination of that probably helps.
Okay, thank you. That was very reassuring. We have one last question. I hope Dr. Chetan is okay with the time. Dr. Uma wants to know regarding if there's any difference between counseling and problem solving in children.
Counseling and problem solving?
Problem solving. Any difference in children?
Oh, you mean in the strategies?
I think I would ask Dr. Uma to just unmute and ask it herself so that we are clear. Dr. Uma, you can just unmute yourself. Yeah, you can ask a question. Dr. Uma?
Hello, ma'am. I am audible?
Yeah, you're audible. Please go ahead.
Thank you for the presentation, ma'am. You told about fear concept. In the fear concept, there is a problem solving in children for anxiety. And when you are dealing with the young children, you have applied the principles of problem solving. But how about counseling in children? What is the difference between your old older children, we are able to go for problem solving. But when it comes to counseling in children, how do you go?
It's more really about using developmentally appropriate language. The principles are all the same. Absolutely the same. So if you read the Coping Guide manual, you'll think that it reads similarly to your CBT manuals, maybe for adults. It's just that how you're going to adapt it and how you're going to present the content to kids, how you're going to use very simplified language, how you're going to simplify your relaxation strategies. That is really what essentially makes the difference. But it's not dramatically different from how we would actually apply CBT even in older individuals. And problem solving, yes, I can understand that whole, the process of making the algorithm and the decision tree for young children may be difficult. So you'd have to kind of adapt, out of all of those skills, which one you feel is suitable for your child, right? So for some children, if you just feel that you want to replace anxious self-talk with more positive or coping self-talk, then you just do that, because that's simplest and probably something that particular child can assimilate. So it's just about adapting. I don't think there's a huge difference.
Okay, that brings us to the end of our presentation. I'd really like to thank Dr. Sreyoshi for a very practical approach to this topic. I think it was very resourceful and clarified a lot of practical aspects for everybody here. Thank you to Dr. Chetan also for giving us this opportunity, and hand it back to Dr. Chetan now.
Thank you, Dr. Sreyoshi, for your excellent presentation, and Dr. Vandana for your moderation. It was a nice presentation in which it was very comprehensive, and it encompassed a lot of newer learning for us also. Thank you both for that. And thank you all for your good participation also. We'll meet next week with another topic from child and adolescent psychiatry. Before we end the meeting, I would like to place on record our sincere thanks to Linux Laboratories Chennai for their support through educational grant, through which we are running this program. We are available on our YouTube channel, NIMHANS Indians, wherein we also have a Facebook page, nimhans.indians, wherein the YouTube channel we have uploaded all the previous videos also. This video was live also on YouTube, and it would be uploaded into YouTube shortly. Thank you, one and all. Stay safe. Take care.
Thank you. Thanks very much for having me. Bye.
You'd be ending the meeting for all.